Hani Lababidi it's my pleasure to present Dr. Hani Lababidi, and he will give us a presentation about how to start a simulation center and simulation in COVID-19 era. Dr. Lababidi is a senior consultant in pulmonary and critical care medicine in King Fahd Medical City in Riyadh, and and at Sanford Health in Fargo in USA. Dr. Lababidi is a founder and previous director of Center for Research, Education and Simulation Enhanced Training, Crescent, in King Fahd Medical City. And he is a co-founder and vice president of the Saudi Society of Simulation in Healthcare. We are welcome, Dr. Lababidi.
Thank you very much, Manan. I will share my screen.
Okay.
Yes, just allow me to share my screen.
Yeah. Okay. Just a minute. You can share now.
Okay. Okay, so my pleasure today to talk with this to you about two lectures. One is how to start a simulation center, and the other one is the simulation in COVID-19 era. These lectures are meant to be during the simulation week, and we're really proud to have this year a lot of lectures during the healthcare simulation 2020. So the objective of my lecture is to identify benefits of simulation center, describe steps of establishing a simulation center, specify costs of establishing the simulation center, and what are the challenges that we face when you start a simulation center. Let's start with the benefit of simulation center. And here, allow me to post like 5 photos, and we'll take a few seconds to please observe these photos. These 5 photos from medical practice and medical education, I would say. I took them from the internet, and they are from different ages. So just like 10 or 15 minutes, watch these photos and just reflect. Do you see any differences over these ages, many years of medical education? So if you look at the picture on your upper left hand, this is from the Islamic era, where you have a teacher and probably an anesthesia guy at the head of the patient, and a nurse helping the surgeon. And behind the curtain, you have the students watching what the master or the professor is doing. If you go back to the middle one, in the upper middle, and it is from Europe, and almost the same, but now the students are closer, and the master, the one who's wearing the hat, is really, you can tell that he's the educator, and the others are learners. In the one on the right side, upper right side, the master took a little bit of a rest, and the students are working with the nurse, and there are also spectaculars like people watching from away from the auditorium. Almost the same thing down on your lower left side, but now it is more neat, more clean. And the last one is from our era now, where you have nice gowns, sterile gowns, but again, the master is in the middle, and the students around him. Now, just if you reflect on these 5 pictures, are there any differences over these years, hundreds of years, and we are still teaching medicine the same? Actually, the only difference that I see is there is more probably clean environment, and the what they are wearing. This is the only difference. It has been the same. So this is really what was about medical education. See one, do one, and teach one until recently. And the reason why we changed is because of 1999, the Institute of Medicine and reported to err as a human. And in this book, they reported about 100,000 deaths per year because of medical error. And this really raised flags about patient safety, and it is now an important agenda item in all governing and licensing bodies. Challenge to improve physician confidence and patient safety, because patient safety now, wherever you go, you hear about patient safety, patient safety, patient safety. So everybody now is interested in patient safety. And this is where we have simulation. In simulation-based medical education, this is an article from 2003, just to tell you that it is now at least more than 17 years now we've been talking about this. It is the best standards of care and training. It is good for error management and patient safety, patient autonomy. We have to respect patient autonomy, and we have to use the resources available under social justice. So these are the ethics behind simulation. And very important quote, patients are to be protected whenever possible, and they are not commodities to be used as conveniences of training. So we don't want to learn on patients. We want to get competent and then treat patients rather than learn on patients and make errors and decrease patient safety. And this is really the idea about simulation and the Miller's pyramid or prism, where we try to teach in simulation knowledge, skills, and attitudes. So all triads of education is there, and we go from knows to knows how to shows, then does, and from novice to beginner to expert, and in terms of proficiency. So this is the whole idea about adult learning, where we want to teach the learners or physicians or nurses different skills, attitude, and knowledge, and really in a different pattern, so you can go in with the proficiency and to mastery level at the end, if we can reach that. So we can teach teaching skills, clinical skills. We can use CME as what we are doing now. We're getting CMEs for these conferences. Teamwork training is best taught in simulation, and this enhances patient safety. If there's a new technology, and nowadays we have a lot of technologies, we're gonna talk in the second lecture about COVID-19, something new to us, and where here we used also simulation. Assessment for licensing and certification, sure, this can be used also for simulation. So we need simulation centers to educate and to perform simulation-based education to improve competency, to decrease stress among healthcare workers, and to reduce medical errors. And if you go through this algorithm, then we have better patient safety in all, and we have also proper distribution of resources. When we decrease medical errors, we have better patients, and also we don't consume a lot of money to treat unnecessarily side effects. So why we need simulation? Because there's a realism in an environment. To make an environment almost the same as in clinical, there's a lot of buy-in, quick buy-in. And initially, when many people thought that, no, we don't want to train on plastics. But from our experience, whenever the learners indulge in the simulation environment, they feel the stress, they feel they buy in very fast, only takes seconds, and they think that this mannequin is a real patient. And this is the fiction contract that they get in their mind because of the realism. Allow repeating uncommon and complex scenarios, provide preparedness to patient care. There is no danger for patients because we're not treating patients here. And critical events, we can pause it and then discuss it and go back to action and correct whatever mishaps happened. We can video record it, we can critique it, or what we call debriefing, and give feedbacks and reflections. All this can be done in simulation, but in real clinical environment, many of these cannot be done, especially about endangering the patient and patient safety. So let's get in the core of the subject, how we can establish a simulation center. Now, if you look at all the experiences worldwide for establishing a simulation center, you have one of two ways. Either you have pre-existing simulation center and somebody tells you, please come and operate this simulation center. It's rather easy, you think so, but it is not, because you have to deal whatever is there, depending on who established the simulation center, what was the need assessment, and so on. Or you can say, please, we want to establish a simulation center. Let's start from scratch, get paper and pens, and start to design the simulation center. So what are these stages for planning? First, we need educational need assessment. Why I need this center? It's very important to address your needs, because depending on this need assessment, there will be the design of the simulation center. So you need to address various needs. Is it for nursing? Is it for physicians? Is it for respiratory therapists, EMS, or it is for a medical city like what we have in King Fahd Medical City, or a university for medical students, and so on. You need to have a gap analysis between the current and desired condition, or what you want. So do we have anything now? Do we have any equipment? Do we have any space? And what are the expected growth and needs in the future? I mentioned the types of healthcare providers to be trained, and what are the available tools for training so we can plan better. The second step is have a wish list. And I like this step, because in this step, you have to be very wishful and dream. What is the dreams or wish list that you need to be included in this simulation center? It's okay to dream. Some will say, no, this may not happen. Okay. Then even if it is a long list, then you can go and cut it down and remove things from this wish list. But at least be a dreamer and put a long list of things that you want to wish to include in this center. Later on, what you will find is you have more realistic plan that can be constructed, okay? And depending on the available resources. So have a wish list, then resources, then finally reach a compromise, which is the realistic plan of the simulation center. Number three, feasibility. And this is very important. There is something that I call it HENC syndrome. Every hospital wants to make a simulation center because it's mine. And actually, you need to look at feasibility. Is it like cost effective? What's the roadmap? What's the business plan for this? Can I do without it? And can I outsource the simulation training to somebody else? Is it cheaper for me or not? So feasibility is very important to see if it is cost effective. Simulation centers cost a lot. The second step, this is the fourth step, sorry, so to involve stakeholders. Very important to involve stakeholders early on in the game. And stakeholders are all the people who will help in establishing the simulation center, be trained in the simulation center, educate in the simulation center, and don't be surprised if you include patients and relatives. It's very nice to include like 360 degrees stakeholders, inside and outside stakeholders, so you can plan better your center and know exactly what you want to do. Now for the space, in the space of this design of the simulation center, you have to integrate three types of space. You have clinical simulation and non-clinical simulation, so the simulation area. You have education space, and you have supporting services. So these are the three types of spaces that you need to have in the simulation center. It is an educational center or space or building or flat, whatever you want to have. So you need to have also educational areas like meeting room, debriefing room, classrooms probably, as well as supporting services that I will talk later on. Sure, simulation areas are very important, and here you can have a multi-purpose versus like OR-like or ER-like or a specific areas of simulation, depend what are your needs. So you need also to see how there's a flow of trainees within this center. Very important about storage space for equipment and consumables. And many times we feel that we are running out of storage spaces. So you need to have storage spaces. You need to have offices for the people who works in this, and then decide: do you need to have a wet lab or not? Having a wet lab will add tremendous amount of reals to your budget, because there's a lot of specification to have an animal lab or cadaver lab, and these are very, very expensive. So if you're planning to have it, you need to plan this from beginning, because there are different engineering specification for this. Let's come now to money and space. So this is a common question I get asked. Okay, how do we calculate the space needed? And this is from my own experience, so it is not published yet, but this is going around and really seeing lots of simulation centers and make the math. Usually, what we need is 3 to 8 learners per meter square per year. And this depends how you look at it, or the better way I look at it is learners' hours. What do we mean by learners' hours? Like if you have a learner who comes to your center, who get trained for 4 hours, so this is 4 learners' hours. These learners come to your center 3 times a year, each time 4 hours, so 12 learner hours. So this is where we got learner hours is more specific, because some learners come for only 2 hours, other learners come for 3 days. Like medical students, when they have their physical exam block, they come for longer hours compared to consultants who come only for a small workshop just for 6 hours or 4 hours, and they go away. And probably once or twice a year, no more. So calculating it as learners' hours is more important. So let's say if you have like 25,000 meters square, then you can train at least 75 to 500 learner hours. And this is a very good number. So this is where you can look at this. Now, we're talking here working 1 shift, so 8-hour shift, but sure, you can increase this even more than double if you extend working hours to double shift or more. The other way around to make the calculation, suppose you have a university and they have 1,000 students, healthcare students, EMS, nursing, respiratory therapists, and so on, pharmacists, and so on. So each will need at least like 4 hours per week of simulation for 32 weeks. Universities don't work for 52 weeks, as you know. There's vacations and there's like during summer, usually it is not full load. So there is, you make the calculations and it comes to 128,000 learning hours per year. And then they need a simulation center, which is about 6,400 meters square. Always have a margin of error and some percentage for expansion. And probably you can ask for 8,000 meters square simulation center, and you can train this amount, about 1,000 students in this university. It will cover their training. Now, what comes in cost, so we talked about the space cost. We talk about 2 things. We talk about capital cost and operational cost. Unfortunately, when people want to establish a simulation center, they only talk about capital cost. And because they get like money to build and get equipment, rather it used to be easy, but nowadays it's not that easy, but it is doable. And they forget about operational costs. Operational costs are very important. Otherwise, you will have a center and you cannot operate because you don't have enough budget to operate this center. So what are the capital costs? It is like for structural cost to build the building. Sure, cost of land depends where you want to put it. In Riyadh, what area of Riyadh, in Jeddah, in Eastern Province. So cost of land, this is, I'm not gonna talk about it because it varies a lot depending where you're gonna put it and if you're gonna pay for it or it is part of the university or so on. Let's talk about construction cost. And this is how my approach to construction cost of a simulation center. If you want to build a residential construction, a house in Saudi Arabia, in Riyadh, for instance, you need about 4,000 Saudi riyal per meter square, and it is a decent house. It's not the super duper deluxe residential house, but it is very acceptable and a high standard. While if you want to build a hospital, the cost per meter square goes up to 14,000. Why? Because there's a lot of infrastructure in the hospital, and the standard for hospitals are totally different than residential. Even the kind of paint, the kind of everything, the tiles, the ceramics, everything is different. You need to have really a very high standard, and also the mechanical and electrical engineering is totally different in hospitals compared to residential. So for simulation center, it is not a hospital for sure, and it is not a house, a residential for sure. So it is about 7,000 Saudi riyal per meter square. You can get a good level of simulation center. So if we go back to our example, an 8,000 meter square, this will cost you about 56 million Saudi riyal just for the building. We're not talking about equipment. Now, equipment, it all depends on what you want to have in your center. So I can't put just a list that you need this much of money. If you only need task trainer, they're not that expensive. You need high tech, high fidelity, virtual reality, augmented reality. Yes, they are very expensive, and maintenance is very expensive. Now, when you want to make the calculation, always in business model, we say, okay, over how long I would put the depreciation of this equipment. It is safely to say, put it at 5 years. Even the risk trainer, you can use it for 7 years until they are really like turn apart and you cannot use it anymore. Now, be careful. Many centers in the area, they are designed by the suppliers of the equipment. And this is, for me, is a no-no. Because what a supplier wants, he wants to put his equipment in this center. So he designed the center according to his equipment, what he has equipment, rather than what is your need. So please, this is my advice to anyone who wants to operate or establish a center. Never get a supplier to design or like a equipment company, simulation equipment company to design your center. It won't work. You'll have a lot of problems. It's better to have equipment from different companies rather than from one company. Otherwise, you won't catch all you need. Now we come to the operation cost, and as I said, it is very important. And usually, it is about 80% of the operation cost goes to salaries. So you need to have technicians, educators, secretaries, administrative staff, and then also you need to have consumables. We consume a lot of things that, in the simulation center, and also you need to pay for utilities, electricity, and also cleaning and water and so on. So these are operational costs. You need to take it into consideration. Otherwise, you'll have a center, but you cannot operate. Now, I didn't put here that the equipment that you need to purchase on regular basis, you can put it under consumables because you consume equipments, and this varies depending on what is your need and what is the size of your center. Now, what are the challenges of starting a simulation center? There are too many, but this is just a short list about 7 items. I put capability and capacity. What is this simulation center is capable of, and what is the capacity? You need champions. If you don't have champions, you cannot have a simulation center. And you call champions, I call them crazy people. We were all crazy people when we started, and when we had this ideas about starting a simulation center, the administrator said, "You are crazy. What are you talking about?" But because we are crazy, we were champions. You need to have like a curriculum, training, and assessment of these training activities, and there are various standards that you need to be aware of and where to put the bar. The overall strategy. what is the strategy locally, nationally, regionally. Here in Saudi Arabia, we are so advanced in simulation compared to other European countries and even Western countries. I'm not talking about the Middle East. We are far more advanced than many countries in the region. And you need to have people in high hierarchy to buy in and believe in this project. Otherwise, they will not pay. And what is the cost effectiveness? What you're going to put as money and what your outcome. And also time. Time is very important. So you don't want to plan something and have it after 25 years. The needs are different, finance are different, and people who will benefit from this are different. Now, I'm going to talk a few minutes to talk about faculty development. You cannot have a center without faculty. Faculty are very important. So start early on planning to develop faculty, even before starting the building, because faculty development takes time. And there is a culture that you need to build in your institution about simulation-based education. It is a paradigm shift in training. So it's a different kind of training. Nowadays, it's more acceptable than 15 years ago when we started in this field. It was so difficult to convince people to use simulation. You need to have faculty development in scenario, design, facilitation, and debriefing. Simulation technicians is a real challenge because there is no university that graduates simulation technicians. So build your own capacity. And also establish faculty maintenance program to keep them all up to date and ready for all these changes. Very good strategy is to partner with other centers so you can always be at the edge of technology and science. You cannot have a simulation center, it's education, it is university, it's like academic without research strategy, and have research strategy early on. Anything you do can be a project for research. It is like a human behavior. Adult learning is a very endless amount of research you can do. So raise questions and try to answer these questions and aim at evidence-based and outcome-driven research. This will help to convince the high administrator to pay for these technologies. I'm going to put few references for you, and that will help you. And actually, these are some of the articles I wrote and the textbook chapters. So, establishing a clinical simulation center. It was a recommendation from an expert panel from the international conference that we did back in 2015 in Dhahran with the military. There's an article about Crescent, our center at simulation at King Fahd Medical City. It is in Journal of Surgical Simulation, about the same. There is about simulation hospital, a model in a textbook for bioengineering for surgery. And also recently, I published a simulation in Medical City, which is a case study of the King Fahd Medical City, and there's a lot of lessons that we learned. With this, I will end and invite any questions before I go to my second lecture.
Thank you, Dr. Lababidi. We are really grateful for the time and the effort, and the topic is really beneficial, especially now all the postgraduate program, they start to do the integration of simulation in their curriculum. So I think I was just saying to Amani that everyone need this. Every hospital or centers having their program need to know about this. So if you have any questions, so if you can just raise the hand, I can unmute the mic. So I have a question regarding to the hospitals that they don't have a capability or the space. So is it okay to start like a skill lab or a small area or a big room in the hospital and starting like scratch?
Sure. So you don't have to build a big simulation center and to start a simulation center. You can start small, and you can see any area which is available in the classroom. And especially when you have task training, and now there's also mobile equipment that you can use. Even you can use what we call in situ simulation. So take simulation to the clinical area. So you have to take the simulation equipment, the mannequin, for instance, and so on, to ER or to ICU. Find an empty bed and schedule to have training in that area. Now, there are certain standards for simulation, in situ simulation, that you have to take care of, and also certain precautions. But this is an alternative if you don't have a simulation center. So small classrooms, you can use it. You can have even debriefing in another room. So there's a lot of things that you can do. So simulation, you don't need to have a super duper big center for simulation.
So Isam Turkestani say, many hospital has life support training department. What is they start from there? So Isam is asking if any there is some hospital have the life support training center. So can they start from this life support centers?
Yeah, very good question, Isam. And I think this is how we started. I'm talking 15, 16 years ago, we started with having a life support center because this was the only thing available at that time. So if you look at the life support courses, they are simulation-based education, especially if you go to the advanced one, where you have debriefing, you have scenarios, and you have hands-on training. So yes, you can start from there and then expand. And but make sure that you practice the life support courses as they should be, with debriefing and so on. But it is a very good start, and then you can expand. And with time, you can learn more and take more experience, have more experience in this field.
Any questions? Okay, would you like to move to the second lecture?
Sure.
So the second lecture will be, or the second presentation will be on simulation in COVID-19 era. So can you start, Dr. Lababidi?
I need to share my screen. Do you see my screen?
Just no, maybe you need to share it. You need to share the screen. Yes, now we are seeing.
Okay, so the second lecture, I'm going to talk about simulation in COVID-19 era. So we cannot, we have to be up to date. And what are the simulation-based education in COVID-19 era? Let's see, okay. So the objective is to identify the impact of COVID-19 on simulation, discuss some of the COVID-19 related simulation training, and define what we call the new normal after COVID-19. And everybody's now is what is the new normal, is the terminology that they are using. It is something really, I don't know to call it fascinating or difficult, but it's a great learning experience during these 9 months or a little bit more of really COVID-19 that we never had this experience before. Whether bad or wrong, but at least we are learning from this experience. So the COVID-19 and academia, sure, the pandemic represent a major challenge for academic medicine and clinical training institutions. And we all had an impact on this. Clinical rotations and teaching sessions all have been suspended. And this is to protect the learners, but also to protect their families. So we don't want a learner to come to the center, catch COVID-19 and goes back to his grandma or grandpa and give them the COVID-19. So we need to protect both learners and their vulnerable patient population. So we looked for alternatives. Worldwide, we looked for alternatives for clinical training. And teleteaching, telemedicine, and teleconferencing is the new normal. We're having now conferences instead of everybody coming to same lecture room, we're having it online. And we have to be practical, and then for skills, professionals need to practice. Yes, they can learn on the web and on teleconferencing, but they need to practice. So we need to have a compromise between. And we know, as I mentioned in the previous lecture, that clinical simulation is an effective and efficient solution for training. So why not training with COVID-19 pandemic as well? Opportunities for simulation-based education in COVID provide consistent benefit to training in a safe and harmless environment. So you don't have to go to the hospital. It is only simulation center. And learners are expected to replace hospital-based training with SPE. More they can do in the simulation center, less contact with patients and contagious diseases, and decrease mistakes and increase safety of trainees and patients as well. Simulation training for COVID-19, there's new practices that we are taking and new guidelines that affecting our practices with COVID-19. So whenever there is a new guidelines, we need to train healthcare workers more about these guidelines. Now, I remember that we were trained on PAPR, the powered air purifying respirator, back with the Ebola. But from the Ebola, which has been like 5 years, we didn't use the PAPR. So now we need to train our healthcare workers how to use the PAPR, the PPEs, the personal protective equipment also, the proper donning and doffing, airway management. I'm going to have some talk about it. How we transport, how we transfer COVID-19 patients. This is different than just regular patients. And how we can be prepared ourselves for COVID-19. This is some of the work that we did at King Fahd Medical City. So, and we published this article in BMJ Steel. So this is simulation-based training program and preparedness testing for COVID-19 using system integration. We did this back in March. So by March, you know, like if you go back in the history of COVID started, and we knew about it in December in China, but nothing serious till like January in Italy, and then France and Spain and so on, and didn't reach states till about early March, and didn't reach us till around May. So we started preparing in March. We thought that this is coming, and you know, around that everybody in the Ministry of Health and in the country was preparing for the COVID-19 pandemic. In that exercise, we did two things. We said, let's test our preparedness for COVID-19, and let's improve our skills training for COVID-19. So the first project was a full-scale COVID-19 simulation-based disaster exercise objective. And we included EMS response with nurses, ER, and ICU, and everybody from pre-hospital to discharge. So like screening and discharge or admission to the hospital. We evaluated the ED response dealing with suspected COVID as per the new guidelines, which were developed by Ministry of Health and Wiqaya. And we assessed the infection control measures when dealing with COVID-19 cases. And we conducted this exercise in March 11. We had 6 simulation scenarios. So we used 6 SPs. These are people presenting to the emergency room as unknown. So the nurses didn't know about it. And we used one mannequin. We put a mannequin in one of the rooms where this SP is admitted as a patient. Then we switch it to a mannequin so they can practice on the mannequin rather than the SPs. So we had around 7 healthcare workers involved and 14 simulationists who are like, it is a combination from disaster planning, who are excellent in simulation and were trained for simulation, and also simulation educators and curriculum development from Crescent. This is one of the tables in the article, and we looked at the strengths and challenges. So there were people who were recording the observations and what they see, and then corrective actions were taken immediately or in the coming few days. Let me go to challenges, and sometimes these challenges are, you think they are simple, but this really happened. And this is the beauty of having an unknown or noticed or declared exercise, disaster exercise. So people get to practice what they practice in real life. So one of the challenges, the EMS are, they know to, like if they bring a patient, they take back their linen with them. So they keep their linen inventory. So this should not be used in COVID. They cannot take their linen. So simple, but yes, it can happen and can cause infection to the EMS people or the people that will get to this EMS vehicle again. Some of the nurses were not wearing the proper PPE, and it's mainly the size of the N95. So, you know, N95 has different sizes. So depending, still they are not used to the different sizes and the fit testing. So we noticed this. There's like cleaning for everything, but the queuing machine, there is a queuing machine that when you come to the ER, you take a number, there was no proper cleaning for that. Now, we noticed that when we want to discharge patients who don't need to be in the hospital, they go to isolation, home isolation. Then we didn't have an instruction for home isolation. And remember, this early on in the pandemic for Saudi Arabia. So now we have all these resources, and we didn't find a designated party to transfer back quarantined healthcare workers to their quarantine space. And we thought that security staff in the quarantine area need to have more training. These are some challenges that we got and were corrected on timely basis. The second project was to train task force, train the healthcare workers on definition and epidemiology, symptom transmission of COVID, what is the competency of donning and doffing PPEs, how to use peppers, and how to clean medical equipment after cases, and recognize the importance of speaking up. We felt that this is a very important about speaking up regarding infection control measures. And we had like 5 stations, and these stations were done at Crescent. So at that time, everything stopped. So there was no simulation courses anymore, no training, except we got a special permission to run these courses because it is mandatory as per the administration. And we used blended learning. So we had videos on the website of the hospital, and about more than 3,500 healthcare workers, they could complete these modules, and more than 600 came to the center. And these are the front liners who, for COVID, and were trained in the center and complete a hands-on training. Now, when we published the article, their number was 375. Now, this is the course evaluation, and we were pretty good, but look at the course has enough hands-on practice, only 66%. So people wanted more hands-on, but sure, we had to restraints of the, because of the infection, and we don't want overcrowding in the center. So we had people, however, people asked for more hands-on as always. The second example that I want to bring to your attention is what we did in the ICU. You know, with the COVID-19, we had new recommendations for how to intubate patients in ICU and ER and anesthesia. And sure, in ICU, we had an in situ room for simulation. So we ran intubation courses for all frontliners who are supposed to be intubating a patient with COVID. And here we use two techniques. One is have a nylon cover over the whole patient and the box. Now, what turned out, people like the nylon cover more than box. There's a limitation of hands motion. So we really didn't use the hand box except for a couple of times, but everybody used the nylon. But we ran all these courses. We didn't publish it yet, but it is, inshallah, it will be published soon. These are some of the pictures that taken, how to ambu bag under the cover and how to put a clamp to the gown of the intubator with a paper, while the RT here and the nurse are with the N95 helping the physician to intubate, and the most senior physician intubating, most experienced one. And we run these courses for, like it is a interprofessional simulation for nurses, physicians, and for respiratory therapists. The third one, what we did also, one of our colleagues was interested in having the aerosol dispersion while using the high flow. And if the patient is coughing, so we have a simulated cough. And we did also in simulation. So this is you see the head of the mannequin now with the wood lamp and with the fluorescein as the expectoration from the cough. And we put a mask. So if you have a high flow, you see this expectoration. And this is a like wall panel in the ICU, and you see fluorescein on it. So it really disperses all over the place. While if you just put a mask over this face, then really you protect the healthcare workers. And this is another simulation-based research that was done because of COVID. Now, probably some of you know about this, the 5 C's, the COVID-19 critical care crash course. And this course was made by really key opinion leaders in simulation and critical care, under the sponsored by the Saudi Commission for Health Specialties. It was very good approach and thought. We trained a lot of physicians in our center on this course, and I know physicians were trained all over the kingdom using the same course, and it is very well written, very well written objectives and scenarios, and it is a kind of uniform training of non-ICU physicians if they need to come and pitch in and help. And we had a lot of physicians coming to help us in ICU when we reached our maximum in June and July. So this was a very good course. And unfortunately, there was no research like appendix to this course. I wish that there was a research question. If everybody collected data, I think there are hundreds or thousands of physicians trained over the different centers. What I got, it is comments from many centers that wherever there are simulationists, part of the Saudi Society for Simulation in Healthcare, the course was really well taken and well delivered. And this is what we are proud of all of you at the Saudi Society for Simulation in Healthcare, that really you guys have to be the front runners in practicing simulation in the Kingdom of Saudi Arabia. And this is why we have all these courses, so you can get really all the information and be pioneers in your institution for whatever simulation course. So what are the challenges for in COVID-19 when you conduct simulation-based activity? You need to have social distancing. It is a must now. Frequency of cleaning and disinfecting the simulation center, including the mannequin. So now you need to clean the mannequin more frequently. We used just to clean the mannequin at the end of the course, but now you need to do it more frequently. And managing supply of cleaning products. At one time, even in hospitals, we're having shortages in cleaning products and on PPEs. And when we run courses in our center at Crescent, we ask the learners to deal with it as if they are in a real environment. So they wear the full PPEs when they're conducting scenarios. So, you know, the yellow gowns, the masks, the head cover, and so on, and the gloves. And these days, there's a kind of shortage. Now, alhamdulillah, we're back to normal because COVID-19 is much less than before. The other challenges is if you want to loan equipment or in situ, you have to clean this equipment. There is psychological stress of healthcare workers and the educator, and I felt this when we had the in situ simulation in our ICU. So we have infection control with us so as an observer, and they can do the feedback and debriefing. And we have also the head nurse and the respiratory therapy supervisor. So all of them say, okay, why should I come to the ICU? And there are COVID cases. So I'm more exposed now, and there is a stress among the educators as well. So why should I conduct all these courses and get myself exposed more to the environment where COVID patients are in? There is also the stress that I may transmit COVID to my family, and this is very stressful. And there is what we call the new normal. Everybody is now trying to live with the new normal with COVID. Now, the Saudi Society for Simulation in Healthcare really pioneered in having a roadmap for simulation. And this, by the way, roadmap that was made by the experts in the Saudi Society for Simulation in Healthcare are now part of the guidelines that universities and medical schools have adapted. So please be proud of your work. Our standards has been adapted by other universities in Saudi Arabia and centers. And we used a lot of wiqaya guidelines. And this is the beauty of having a really well-referenced and a lot of excellent work by Ministry of Health. And I'm going to show you a lot of things that has been made. So you don't have to really invent the wheel again. There are a lot of guidelines that has been put by experts. So just use them, and this is spread them and disseminate them. So the safe roadmap for simulation, what we recommend that to raise awareness among all workers and learners about COVID. And we recommend that to have a representative of the simulation, one person or a group of people, depend on the size of the simulation center, are assigned to carry out education about COVID to learners, workers, and educators. We need to have a communication plan, lectures, seminars, webinars, whatever, posters, brochures, websites about hand washing, etiquette of coughing and sneezing, how to protect yourself, how to protect your colleagues. And really, if you look at, I put some pictures from the Ministry of Health, like brochures and posters. كلنا مسؤول. This is from the Ministry of Health. There are a lot of efforts done by Ministry of Health and Wiqaya, so it is available, and you can use these posters in your center as well. And you need to have community informed with accurate information from credible source of information. You know now, because of COVID, every day you have a new information, and some of this information is false information. So please, we need a credible information. And again, refer to the Ministry of Health, and there are like apps, applications on smartphones, there's on computers and so on, all available. And we need to have a reporting mechanisms, and we be very transparent whenever someone has symptoms, and spread the culture of proper use of alcohol-based hand sanitizer. Now, everybody now, we clean our hands in the hospital 100 times probably. Every time we go in, we go out. These things we are doing more frequently, more vigilantly these days because of the COVID-19. So these are the recommendations. So raise up awareness about the seasonal flu vaccination, which now the time for it, for learners and simulation center, because you don't want to get confused if you get a flu that this is COVID and vice versa. And raise importance about urgently visiting the doctor in case of respiratory symptoms. And this is the Markaz توعوي بطرق الكورونا that is related to Ministry of Health. Provide adequate supply of hand sanitizer and soap in the simulation center so people can clean, and also clean surfaces like door knobs, door handles, dining tables, seat rest, elevator buttons, and on regular basis, so to reduce transmission of COVID. All classroom simulation areas, the briefing rooms should be well ventilated, and you have the reporting of any infectious disease according to the guidelines of and regulations of Ministry of Health, and to have fewer learners. Yesterday I had airway course, we used to have 18 to 24 learners, I had only 6 learners. So we changed, it is a complete change in our simulation-based education. Now, if the learner has COVID-19, the simulation center need to identify all the contacts. So you need to have a logbook, you need electronic or written. We at Crescent, we have everything now electronic, so we don't have papers at all. Everything is electronic. You come, you sign in, we know exactly who are in the center and who get in contact. And if this learner got infected by COVID, he or she should not come back to the simulation center. So let's say a medical student, unless he is cleared by infection control or by a physician, so he will not infect other people. All registration areas and simulation areas, even stairs, escalators, they need to have proper distance and clean accordingly, and also temperature check. Whether you believe it or not, or you say, oh, it is too late, but again, it is a kind of a standard now, and we have like a camera, heat camera at the entrance of the building, so anyone with elevated temperature, he or she will know that, and they will have to check a physician before coming to the center. You need to have a proper signage to get the information of COVID. Avoid gathering and unnecessary gathering. You know, we have a lot of social talking in simulation. You have to use distancing and decrease gathering as much as possible, and to have enough PPEs, and identify high-risk staff, elderly staff, patients with comorbidities, so they won't get COVID, hopefully. So simulators, we need to clean them, and simulators are not difficult to clean, but they have special specification on how to clean and with what material. So you have different simulators, you have different cleaning. Those with electronics, make sure that you don't get water and soap on them. Otherwise, electrocution can happen because there's like, and they can malfunction. And what we recommend that there's manufacturer guidelines for cleaning with disposable wiping material that you can use for this. Also, think about the computer touch screen keyboards. These also need to be cleaned as well. They're not individual for individual use, for public. You shouldn't use bleach or abrasive material on simulators. And if you're using virtual reality headsets, so this virtual reality, they are used from one person to another, then you need to have a disposable cover. You can use a cover for them, a special cover, and disinfect them after use. This is need to be done really. Now we put a roadmap for simulation. This is the kind of an infogram. It is present in our website, where from arrival at simulation center to registration, to health safety, caring of simulators, role of educators, role of learners, and during simulation session, what should be done during the briefing until you exit from simulation center. From the whole journey, there are certain roadmap and checks that you need to carry and take care of for a safe simulation. With this, I will end and invite any questions for the lecture.
Thank you, Dr. Lababidi. If you have any questions, you can proceed.
I have a question for Dr. Hani.
Yes, go ahead.
From your experience, what we can do to prepare, inshallah ما يجي شيء, بس to prepare for the second possible if we have a surge of COVID-19 again. From your experience from last year and as ICU consultant, what do you think we can do?
بعدين في الليل أحط لك.
Okay, so the question that we have is what are the precautions if we have a second wave? Now,
Exactly.
I can tell from experience in simulation and in ICU that, alhamdulillah, we did really well. I'm not like here flat, giving credit to anyone, but really we did well with the first wave, and this is because of all the mitigation attempts from the Ministry of Health and from the really administrators and physicians and nurses. And alhamdulillah, we were able to absorb the first wave, and rather some days they were tough, but we survived this and with little losses. So I think we are now more prepared. Something that we made sure in our ICUs and in our simulation center that we have now more PPEs. We thought that we have enough PPEs, but when the surge came, we found that we need more PPEs. So now going back to normal, I did talk about this in my lecture, but like what we're having at Crescent is really very nice. My colleagues at Crescent, they had a new plan to come back slowly with simulation courses. So they divide the simulation courses into 3 categories: the red, green, and the yellow. So green, we started, these are needed courses, and we started coming back and scheduling these courses. And with time, they're gonna have back to full normal, inshallah, within coming 3 to 4 months. So you need to have a plan for COVID-19. When we're gonna have the vaccine, Allahu A'lam. I hope it will be, inshallah, soon, so we can go back to normal life. But as we all know, our lives will be not back to normal, never back to normal after this tough year.
الله يعطيك العافية.
شكرا لك دكتور. Thank you.
Thank you very much.
أعتقد ما في other questions يعني شايفتهم.
Okay. Thank you very much.
يعطيك العافية يا رب.
يعطيك العافية.
السلام عليكم.
For participants, please send an email للإيميل اللي جاكم so we can know what's your name actually, because everybody entering in their different nicknames. So send it for Mariam with the same email that she sent for you through the link, so we can provide you with a certificate at the end of the same week إذا ممكن لو سمحتوا جميعا. Well, thank you very much, Dr. Hani. I really enjoy you. You present actually 2 lectures, not 1. But thank you so much for your effort and your help.
Most welcome. السلام عليكم.
وعليكم السلام.
شكرا يا منال، الله يعطيك العافية.
شكرا أماني، الله يعطيك العافية.